Gabriel, and thank you, Mary, for giving me the opportunity, I suppose, to share with you my experience of using the DOPS, as we'll call it, the DOPS, or the DOPS as we've come to know it. And what I've decided to do, I suppose, is just to share with you my experience in relation to using the DOPS on the Master's Advanced Practice Gastroenterology, which encompasses endoscopy skills training for our master's students. Professor O'Connor Lazarina is using a DOPS assessment type tool on the specialist diabetes programme. She's developed a DOPS tool in relation to diabetes care and foot care and foot assessment. My only experience to date in using the DOPS has been essentially with the endoscopy training programme. So I suppose I'd like to give you an overview of the DOPS assessment process, explain to you how we're using it as a formative and a summative assessment in endoscopy training. And the really nice thing about the tool is that it works very well as a formative assessment. The same tool is used for summative assessment, so there's a nice progression and follow through, I think, in relation to learning. I suppose to consider the use of the DOPS as an assessment structure, I suppose, want to clarify with you that I don't have a magic bullet, as Jonathan said, in relation to DOPS. It's very much a work in progress, and we're just coming now, currently this semester, in relation to the end of the 2-year cycle for the master's programme. So I suppose it's all just fitting into place. Excuse me. So just to clarify, I suppose, at the start, what is DOPS? And to get an overview of what DOPS is, a direct observation of procedure or skills. It's an assessment tool designed to evaluate the performance of a trainee undertaking a practical procedure against a structured checklist. And as we all know in relation to assessment, there are a lot of pros and cons about a structured checklist. The focus in DOPS that we're using in endoscopy very much focused on practical skills and very much a formative process. And I suppose the nice thing about the DOPS tool that we have adopted from the JAG, and I'm going to explain to you in a moment about JAG, the trainee receives immediate feedback to identify strengths and areas for development. So that's a really nice part, I think, in relation to the learning. So I suppose just to give you a little bit of background in, I suppose, how we arrived at this juncture in relation to using the DOPS assessment as a mode of assessment. My colleagues, Dr. Mary Casey and Martin, head of school, are very much involved in the tendering process back in 2011 for the new programme with the National Cancer Screening Group and St Vincent's University Hospital Group to develop a programme, a master's programme for nursing, which encompassed prescribing of medication and also endoscopy training. So our school won that tender, and we commenced the programme in May 2015. Now, the title of the programme, I suppose, in many ways is quite wordy. So you're thinking about A&P gastroenterology care, colorectal screening and disease management. It includes nurse endoscopy training with a designated clinical mentor. The students are employed in the bowel screen programme, and they have to be employed in CNS, as CNSs within the bowel screen sites. And the plan following the master's programme that this group will progress to A&Ps in gastroenterology. The training in relation to endoscopy is based on the Joint Advisory Group on GI endoscopy. And all National Screening Service bowel screen units within Ireland are JAG accredited. And the JAG essentially is a joint advisory group on GI endoscopy, initially established in the UK as an accreditation scheme, a pathway of quality improvement, and essentially, I suppose, maintenance of JAG standards. In Ireland, and I suppose that initial joint advisory group, the remit was standards of teaching, training and curricula for trainees for endoscopy in the UK. When the bowel screen programme was established within the NHS, the JAG was established then as a quality assurance overview and accreditation process for all screening sites. And in Ireland, the quality assurance overview for colorectal screening is supported through the UK JAG, the Joint Advisory Group on GI. And In addition, in Ireland, we have a full quality assurance process in relation to the RCPI, the RCSI, the HSE Quality and Patient Safety Directorate and the Department of Health are overviewing the quality assurance in relation to bowel screen. And I suppose I provide all that detail for you in relation to JAG so that it's clear, I suppose, that the tool we're using is the JAG tool. And the JAG tool has been developed in collaboration, obviously, with our colleagues in St. Vincent's in gastroenterology. Now, this is just a cover page of our tool. We've developed a tool for year 1, year 2, formative tools to cover both years, and also a summative tool for the end of the programme. So the DOPS assessments are actually completed on upper GI endoscopy, colonoscopy and flexible sigmoidoscopy. Under the guidance of Dr. Glenn Doherty, who's our clinical lead in St. Vincent's, we've adapted the tool marginally to focus on diagnostic endoscopy. The JAG tool that we use for endoscopy assessment is the same tool used for medical endoscopists. Our focus in the nursing focus is on diagnostic as opposed to therapeutic. However, some of our nurses have moved towards some therapeutic procedures like removal of basic polypectomy procedures. However, our focus in our education is on diagnostic as opposed to therapeutic. So Dr. Doherty, we adopted the tool and we developed the tool, and I'm going to show you the tool now in a minute on the camera when I just explain it to you a little bit more. So what we're also using, I suppose, the tool is very much a psychomotor skill assessment. We're also using the tool in tandem with recording a clinical log of all cases. And because endoscopy training, I suppose, was so new, and endoscopy skills were so new for our nurse students on the masters, we developed a clinical log where students started to observe, to assist, and move towards independence. So they have a continuum of recording of cases moving from observed to independent. So our formative assessment process over year 1, it's a year module, so it runs over all the semesters, and year 2 in the same way, another year module. The students are required to complete at least one formative DOPS per semester. Most students aren't really using the tool as a learning tool as well, so many are completing more than one formative assessment each semester. And then at the end, we've got a summative process where the student training logs are reviewed, formative DOPS are reviewed and verified. And in order to move towards a summative assessment, the target in relation to procedures is at least 200 independent procedures. So you're thinking about 200 OGDs, 200 flexible sigmoidoscopies and 200 colons. So you can see the requirement over the year is actually, quite demanding. In relation to the summative DOPS then at the end of the programme, each clinical mentor verifies that the student is ready to go towards a summative assessment, and the summative assessment is carried out by an independent assessor in a different site to your own site. So within the bowel screen sites, all the mentors are going to support each other and assess the students from the different sites. I hope all this is making sense. I feel as if I'm talking a lot. So, thanks, Anne. I suppose the nuts and bolts of the assessment is the kind of thing we think about a lot. The grade scale descriptors. We're very familiar with our grade scale descriptors in relation to marking our assignments. There are very clear grade scale descriptors provided within 4 domains. And the 4 domains you can see there, and they essentially are the bread and butter, the nuts and bolts of this assessment. Assessment, consent and communication, safety and sedation, endoscopy skills during the procedure, and then diagnostic and therapeutic ability. The scale is literally 4 to 1, starting with highly skilled, moving obviously towards competent, some standards met, and then accepted standards, but not at a required level as yet. The grade scale descriptors are quite detailed, but they're very useful because they're clearly indicative of what you need to think about, what the assessor needs to think about. There are descriptions for all grades in each of the 4 domains. The key focus is level 3. As we can imagine from all our experience, competent and safe practice throughout the procedure. And the descriptors, I suppose, are a Bible, are very clear indicators for the assessor. Now, I know it's terribly busy, but in relation to the first domain, very much our whole kernel in relation to our nursing, assessment, consent, communication. So you can see there the kind of indicators that we're working towards in relation, and it's very self-explanatory, I suppose, in relation to how we would want to focus on patient care. Good, clear explanation, few omissions, little jargon, respect and dignity for the patient. So very clear indicators, I suppose, in relation to what's expected. The competencies then, and I kind of like the competencies because you've got the overarching structure in relation to the patient journey in endoscopy, understanding the procedure, consideration for the patient, preparation, technical ability, post-procedure, overall ability to perform the procedure. And while I say to you, the focus is on the psychomotor skill, but a really overarching structure is that the patient's journey through endoscopy is safe and competently approached. I see Anne looking at me now. So I'm going to, in a moment now, I'm going to show you the outline of the tool on the camera. But I suppose to say to you that, and I didn't give you any of the background in relation to bowel screen, I think I jumped forward. The bowel screen, we're in the 3rd year of the screening within Ireland. There are 2,000 cases each year of colorectal cancer identified in Ireland. There's a 50% uptake so far in relation to screening. The current cohort of patients being focused on are 60 to 69 age group. 50 to 74 is the expected target group, which will be rolled out after the first programme. And so far, last November, there were 150 cases, so we're almost, I think, up to 200 cases of cancer have been identified. And it is working. While there's a 50% uptake of the initial invite to complete the FIT test, which is like a fecal immunoglobulin test, when patients who have a positive FIT test are actually 90% of people are going forward for colonoscopy. So it is actually working quite well. There are 11 sites currently up and running, with 4 starting now in the second phase. So really it's moving on quite well in relation to the rollout of the bowel screen. I suppose the job of work for us now is to think, to measure, to evaluate the DOPS, think about it as an assessment process. I really do feel that because of the overarching patient approach that I've spoken to you about, I do feel it is all encompassing. It is quite detailed, and I brought down some, I mean, they're very bulky in some way, the documents, but the students really are able to use the formative assessment sheets over and over, and to use them as an assessment and also as a learning tool. Just to say to you that within the UK, there's structured training for nurse endoscopists. We're not actually there yet. The GIN, slightly negative, anyway, we'll go for GIN. Gastrointestinal Endoscopy for Nurses is their website. And there's 2 established nurse endoscopists within Ireland practicing at the moment. One girl in James is an AMP in James and an AMP in Cork. And they're trying to develop a whole, maybe, accreditation process in Ireland for nurse endoscopists, because currently we're working under the medical endoscopist structure. And just to say to you that the Royal College of GP Practice in the UK are now looking at DOPS and thinking about moving it towards what they're calling CEPS, if you'll see here, Clinical Examination and Procedural Skills. And what they're trying to focus on, I think, is the history taken and the patient journey along with the psychomotor skill, recording clinical cases. But sometimes we're actually ahead of the curve and we don't actually realise we are, because we are actually recording cases already. All our advanced practice students record cases as well as their psychomotor skill assessment. So I just want to acknowledge our colleagues in St Vincent's, my colleagues on the AMP team, and I think the clinical mentors within the sites, because really it wouldn't be possible without them. Now I will try and show, I know I'm way over time, maybe if anybody just wants to see this separately, or anyone wants to ask me anything. I know I raced through that. I tried this yesterday and it worked, so yeah. Now, I've a number of the documents here if anybody wants to see them, but I suppose what I really just wanted to show you was the way the indicators, oh no, sorry, apologies. It's this kind of a tool. Obviously one outline for OGD, one outline for flexible sigmoidoscopy and one outline for colonoscopy, moving towards the domains. So it's very structured, very clear. The steps are continual and very much positive, I think, as a formative learning experience. Suffice to say, we're coming to the end of the 2-year programme on the Masters, and our job of work now, I think, is to evaluate it and see how it works or how it has worked for the students. Of the 12 students we have on the programme, they have all come forward to complete a summative DOPS this summer. They've all been signed off by a mentor, which is really, really positive. However, I think being able to arrive at that juncture really demonstrate their nursing experience prior to actually developing or adding on another psychomotor skill in endoscopy.